Hello and welcome to this webinar on Carbapenem Antibiotics. My name is Sallie and I'm the Clinical Communications Coordinator at HPS. So this session will cover how carbapenems are used as well as some of their resistance trends. So carbapenems are considered therapies of last resort, and this is due to their potency and their broad spectrum of activity. However, these agents are increasingly used in Australia and around the world, and this is largely due to the impact of antibiotic resistance. So the carbapenem class of antibiotics includes these three agents here. So you've got ertapenem, imipenem with cilastatin, and meropenem. And carbapenems are classified as beta-lactams as they have that beta-lactam ring that's shown here. So this is a structural feature that is shared with other agents such as penicillins, cephalosporins, monobactams, and most beta-lactamase inhibitors. And beta-lactam antibiotics work by inactivating enzymes in the cell membrane of sensitive bacteria. And the enzymes targeted by these agents are known as penicillin binding proteins. And these proteins are involved in many different aspects of cell wall synthesis. And like most beta-lactam antibiotics, carbapenems are classified as bactericidal, and this is because they kill bacterial cells as an indirect consequence of their action on inhibiting bacterial cell wall synthesis. So carbapenems can be used to treat a range of infections caused by bacteria that are either suspected or proven to be resistant to all other antibiotics. And they may also be utilised for patients who cannot tolerate other antibiotics. So infections treated by carbapenems include urinary tract infections, intra-abdominal infections, lower respiratory tract infections, and skin and soft tissue infections, amongst others. And in the case of meningitis, imipenem and meropenem can both penetrate the CSF when the meninges are inflamed. So this is a useful property in the treatment of meningitis caused by gram-negative bacilli. However, in practice, only meropenem is used for this purpose, as imipenem is associated with seizures. Another important use of carbapenems is in the treatment of infections caused by ESBL-producing bacteria. So some bacteria produce beta-lactamases, which are enzymes that break down beta-lactams, and extended spectrum beta-lactamases, or ESBLs, can break down most beta-lactam antibiotics, including penicillins, cephalosporins, and aztreonam, but not carbapenems. So the increasing impact of ESBL-producing bacteria has increased the global use of carbapenems. And infections caused by ESBL-producing bacteria are associated with poor outcomes and more limited treatment options. And the ability to produce ESBL has only currently been found in gram-negative bacteria. Community and hospital-acquired ESBL-producing Enterobacteriaceae, which includes E. coli and Klebsiella pneumoniae, are quite prevalent worldwide. And they can cause quite a range of infections, all the way from UTIs up to sepsis. And there are many other species that can also produce ESBLs, which some of them are listed here. And in the case of serious infections caused by ESBL-producing bacteria, carbapenems are typically the treatment of choice. So carbapenems have quite a broad spectrum of activity against many gram-positive and gram-negative bacteria, as we can see here. So they're active against many gram-negative bacilli, anaerobes, most enterobacterales, and methicillin-sensitive staphylococci and streptococci. And imipenem and meropenem are both active against Enterococcus faecialis and many strains of Pseudomonas aeruginosa. However, ertapenem is not active against Pseudomonas aeruginosa, E. faecialis, or Acinetobacter. And all three carbapenems are not active against Enterococcus faecium, MRSA, or Stenotrophomonas multifida. So S. multifida is intrinsically resistant to carbapenems, and this is quite an interesting bacteria, as although it doesn't have a high virulence, it can emerge as an opportunistic infection during prolonged carbapenem therapy. And pneumonia and bacteremia are the most common presentations of infection with this bacteria. And treatment options are unfortunately quite limited, as this bacteria is also intrinsically resistant to many other antibiotics. And for patients who are severely immunocompromised or severely unwell, mortality is very high. So resistance to carbapenems is generally mediated by one of these 4 resistance mechanisms. So firstly, bacteria may produce beta-lactamase. So these are enzymes that can hydrolyze beta-lactam antibiotics, and this is quite an important mechanism of resistance. So carbapenems are unaffected by most beta-lactamases, including extended spectrum beta-lactamases. However, there is a subset of beta-lactamases, sometimes called carbapenemases, that can break down nearly all beta-lactam antibiotics, including carbapenems. And one of the ways that this resistance mechanism has been addressed in the past, so with penicillin, is to combine the antibiotic with a beta-lactamase inhibitor. And probably the most common example of this would be amoxicillin with clavulanic acid. However, currently available beta-lactamase inhibitors are not used in combination with carbapenems, simply because they have too limited a spectrum of inhibition. So there's quite a large range of beta-lactamase enzymes, and inhibitors do have different levels of efficacy against each enzyme. And there are a couple of ways that these enzymes can be classified. One of the simplest ways would be the molecular classification scheme. So classes A, C and D hydrolyze their substrates through an active site serine, whereas class B requires divalent cations for hydrolysis, with the cation typically being zinc. So classes A, C and D are often referred to as serine beta-lactamases, and class B can be referred to as metallo-beta-lactamases. And the enzymes capable of breaking down carbapenems typically belong to groups A, B or D, as shaded in grey here. And as you can see in this table, there is no currently available inhibitors that are active against group B enzymes. There are novel beta-lactamase inhibitors that have recently been approved in other countries, and there are more in the development pipeline. So these agents have better activity against carbapenemases, and combination products of meropenem with the inhibitor vaborbactam and imipenem cilastatin with relebactam are available internationally, and it's likely that we'll see products like this coming to Australia in the future. So the genetic information for beta-lactamase enzymes are mostly encoded on plasmids, and these are small molecules of DNA that are physically separate from the cell's chromosomal DNA, and they often contain additional genetic information that provides some kind of advantage in a particular environment. So for bacteria, this often relates to antibiotic resistance. And this can be quite concerning, as plasmids are quite readily transferred to neighbouring bacteria, and this includes different species of bacteria. So that just allows resistance mechanisms to spread quite rapidly. And carbapenemases have been mainly reported in Enterobacteriaceae, Pseudomonas aeruginosa and Acinetobacter baumannii. And carbapenemase producing Enterobacterales, or CPE, is a critical antimicrobial resistance that is monitored by the National Alert System for Critical Antimicrobial Resistances, or CAR-alert for short. An analysis of 2023 CAR-alert data shows increasing reports of CPE in Australian hospitals, and this presents a real concern as CPE is difficult to treat, as effective therapies are often limited and the length of hospital stay is typically prolonged. So another resistance mechanism is reduced access to the cell. So gram-negative bacilli have an outer membrane that is naturally quite effective at keeping beta-lactams out. And to penetrate these cells, beta-lactams usually have to pass through hydrophilic porin protein channels. And mutations can result in a reduced number of these channels being expressed by the bacteria. So this limits the ability of the antibiotic to penetrate the cell. Another option is that a mutation could result in an increased amount of active efflux pumps. So that would remove the antibiotic once it does enter the cell. And mutations could actually result in both of those options, so reduced porin channels and increased efflux pumps. So these combined can lead to carbapenem resistance. And an example of this occurs with Pseudomonas aeruginosa. So while many strains are susceptible to imipenem and meropenem, resistance can emerge during therapy, and this is usually due to reduced production of those porin channels or increased production of those efflux pumps. And one way that's been used to combat this is using aminoglycosides in a synergistic fashion. So aminoglycosides can increase the permeability of Pseudomonas aeruginosa's outer membrane, and studies suggest that the most potent aminoglycoside for this purpose is tobramycin, next up followed by gentamicin and then amikacin. And lastly, we have altered target site. So the target site for carbapenems are those penicillin binding proteins, and any alteration to those proteins can affect the binding of the antibiotic and thereby the sensitivity of the bacteria to that antibiotic. And this resistance mechanism is more likely to be relevant in gram-positive bacteria. So in the Australian setting, carbapenem resistance is currently quite low. It is most commonly seen in the Enterobacter cloacae complex, or ECC. And this is a group of 6 species of Enterobacter that are common causes of hospital-acquired infections such as pneumonia, UTI and sepsis. So the 2023 ORA report, or the Antimicrobial Use and Resistance in Australia report, states that meropenem resistance in ECC is between 1 and 2%. So carbapenem resistance was reported to be much lower in E. coli at less than 0.1% and around 0.3% or less in Klebsiella pneumoniae. And carbapenem resistant Enterobacteriaceae in general is a major concern, and this is because this is a family of bacteria that is a very common cause of infections, and in the case of resistant cases, the mortality rate is quite high. So all carbapenems currently available in Australia are for parenteral administration, and they're approved for use in patients from 3 months of age. They are also primarily eliminated via the kidneys and do require dose adjustments in renal impairment. So ertapenem has the more narrow spectrum of activity compared to the other carbapenems. It is active against most Enterobacterales and anaerobes. However, compared to other carbapenems, it's less active against P. aeruginosa, Acinetobacter and gram-positive bacteria. One of the potential benefits of ertapenem is that it has a longer half-life, which allows once-daily dosing. And it can be administered via IV infusion, which is usually run over 30 minutes, or as an IM injection. And ertapenem has been associated with seizures and other CNS adverse effects, and these are more commonly reported in patients with some kind of pre-existing CNS disorder or impaired renal function, or both. So imipenem is no longer actually marketed in Australia, but it may still be accessed via this special access scheme. And imipenem is the antibiotic component of this product. And this antibiotic is actually inactivated in the kidneys by the enzyme renal dehydropeptidase 1. So when imipenem is administered just on its own, it's rapidly degraded by this enzyme, and so relatively low levels are achieved in the urine. So for this reason, imipenem is always co-formulated with an equivalent amount of cylostatin, and this functions as an inhibitor of the renal dehydropeptidase enzyme. And whenever you see dose recommendations, it just refers to the imipenem component. So imipenem is administered as an IV infusion. Depending on the dose, this is usually run over 20 to 60 minutes. Nausea and vomiting are quite common adverse effects, and they are dose related. So if a patient experiences this during an infusion, you may want to reduce the infusion rate. Imipenem is also associated with CNS adverse effects such as seizures and confusion, and this is of particular concern when high doses are used or for patients with CNS disorders or renal impairment. And lastly, we have meropenem. So this has quite a similar spectrum of activity to imipenem, and whilst seizures have been reported with the use of meropenem, the risk is thought to be much lower compared to other carbapenems. There have been reports of rhabdomyolysis, and therapy is recommended to be discontinued if there are any signs or symptoms of this. Meropenem can be administered as an IV infusion over 15 to 30 minutes. Alternatively, doses can be given as an IV bolus over around 5 minutes. However, there is quite limited data to support bolus injections for doses of 2 grams. So this table just provides a bit of a summary of the usual adult dosing for each carbapenem. Obviously, just bear in mind that individual doses are dependent upon a lot of different factors, including the type of infection, the severity of the infection, and the resistance patterns of the pathogens, as well as the patient's renal function. And lastly, you may be wondering about allergies. So as carbapenems belong to the beta-lactam class, there may be concerns when a patient presents with an allergy to another beta-lactam. And penicillin allergy is obviously one of the most common allergies reported by patients. So for patients who have a confirmed penicillin allergy, a meta-analysis demonstrated that the risk of cross-reactivity to any carbapenem was just 0.87%. So in other words, over 99% of patients who are allergic to a penicillin will actually tolerate a carbapenem. And the advice from the therapeutic guidelines for patients with confirmed penicillin allergy is that a carbapenem can be considered in a supervised setting. However, for patients with a history of a severe cutaneous adverse reaction, a carbapenem should only be considered in critical situations where treatment options are limited. So that would apply to patients with a history of Stevens-Johnson syndrome or toxic epidermal necrolysis. So to conclude, carbapenems are very powerful antibiotics and they have a very broad spectrum of activity. Rates of resistance are currently low but increasing, and we should be making efforts to limit the spread of antibiotic resistance wherever possible. So this includes infection prevention strategies such as hand hygiene, environmental cleaning and waste management, as well as appropriate antimicrobial stewardship programs. And the Australian Commission on Safety and Quality in Healthcare produced some really great resources on AMS, including the Antimicrobial Stewardship in Australian Healthcare. And that document just summarises some of the current evidence around AMS strategies and how they can be implemented. And then you've got the NSQHS standards, which all health facilities should be meeting, as well as the Antimicrobial Stewardship Clinical Care Standard, which describes the care that should be provided to a patient with an infection or at risk of an infection. So thank you so much for viewing this presentation. I hope that you found it useful. If you do have any questions or have any feedback at all, please contact me at sally.drake@hps.com.au. Thank you.